Hi, this is Jim Bussel. I'm emeritus professor at Weill Cornell Medicine in New York. I've worked in thrombocytopenia starting with ITP since 1981. And I thought for this webinar, we would go to talk about the thrombopoietic agents, but not talk about ITP, since the data there is fairly well published. As I understand it, you can hit the question button anytime if you have a question and enter it in the chat room, and then I will save time to try to answer all of the questions or as many as possible at the end. So I'm going to discuss aplastic anemia and chemotherapy-induced thrombocytopenia primarily, and have a couple of info slides at the beginning. These are my disclosures. I do a reasonable amount of consulting for a number of different companies that are interested in this space. These are ITP-related manuscripts, but they pertain mostly to the TPO agent. So the second one is about rituximab, and they're all quite new and relatively not only up-to-date, but encyclopedic in a way. In particular, the International Consensus Report and the ASH guidelines both came out in Blood Advances very late in 2019. I have one set of comments, which is generally, I think, the ASH guidelines, the main focus, as I take it in, given that that's the area I work in, is to not use steroids for very long and not go past 6 to 12 weeks of steroid use, whether prednisone, dexamethasone, methylprednisolone, in the treatment of ITP. So that means if you follow that starting with persistent ITP at 3 to 12 months from diagnosis, you would be using second-line agents. And while there are several weak recommendations, these are based not on evidence-based medicine where people have made comparative studies, because none exist. They're rather based on an online voting that the committee made available to members of ASH so they could say what they thought about different ones. It's important to realize that thrombopoietin and thrombopoietic agents make megakaryocytes, but they don't seem to make actual platelets. So that the platelet production increase tends to be a spin-off of having a great increase in the number of megakaryocytes in the marrow. This is important because if, for example, there is peripheral platelet destruction, then the increased amount of production can overcome that to some extent and increase the platelet count. If, however, there is a defect in the ability of megakaryocytes to make platelets, having a lot more megakaryocytes may have a minimal effect on increasing the platelet count in that setting. And this may pertain to what we'll talk about, especially with chemotherapy-induced thrombocytopenia. There are a number of thrombopoietic agents. By far the best studied are Romiplostim or Nplate and Eltrombopag or Promacta or Revelade. Romiplostim is given subcutaneously weekly. Eltrombopag is given daily by mouth, but requires a very empty stomach. Avatrombopag was licensed in the US more than a year ago for the thrombocytopenia and liver disease, but then was licensed for use in ITP in June of 2019, and they are actively pursuing chemotherapy-induced thrombocytopenia. Eltrombopag is another oral TPO agent that was licensed for thrombocytopenia and liver disease. And what I'm calling the SSS bioagent from China is given subcutaneously daily, but has been licensed in China for longer than Eltrombopag and Romiplostim have been licensed for ITP in the United States, which is since 2008. I will come back to the SSS bioagent and to Avatrombopag a little later. You can see that Eltrombopag here is a very small molecule, and furthermore, it is a chelator. The fact that it will chelate calcium and iron, on the one hand, accounts for some of its special effects, and the fact that it signals in the megakaryocyte very differently from romiplostim and thrombopoietin. Excuse me. That's also the reason for the dietary restrictions, because if it gets a chance to bind calcium or other divalent cations, it becomes inactive. Romiplostim is 4 of an identical peptides that were identified by screening and that were hooked to an IgG1 Fc carrier domain to increase the half-life. Using 2 peptides on each part of the molecule is intended to make it easier to dimerize the receptor. I'm not going to talk about pregnancy further, but I would say that Eltrombopag, because it's a small molecule, and Romiplostim, because it's recycled by FcRn, the neonatal Fc receptor that is responsible for prolonging IgG half-life, would both be expected to go across the placenta if administered to a pregnant woman, and therefore they have not generally been used in that setting. You see here a schema for the binding of thrombopoietin, romiplostim, and the SSS bioagent to the TPO receptor in the extracellular portion. The receptor gets dimerized, signals through several pathways, and platelet production is increased by virtue of proliferation of megakaryocytes. In contrast, Eltrombopag, Avatrombopag, and for that matter, Eltrombopag appear to bind at the cell membrane because there is a histidine to lysine polymorphism there that determines whether they will bind or not. And while in our small study, they seem to signal similarly, in studies of megakaryocytes, what signaling takes place appears to be very different. And this may explain why not responding to one of these does not mean you would not respond to another. And in ITP, surprisingly, literally 50% of patients who don't respond to romiplostim will respond to Eltrombopag and vice versa. And this presumably reflects these differences in binding and signaling and may make a difference in other settings as well. These agents certainly do have some side effects, but in general, they're relatively benign and relatively tolerable agents. In my mind, at least in ITP, the biggest important adverse event is development of thrombosis. We used to say that was independent of the platelet count, but I think approximately 2/3 of the thrombosis is venous, and that is independent of the platelet count. But the arterial thrombosis generally has been restricted largely to patients with an essentially normal count, and this may be an important difference. In the setting where there's the potential to stimulate abnormal cells, like in MDS or AML, there's a risk that these agents could worsen the malignant potential of the marrow. This has been seen with aplastic anemia and in use in MDS. Other side effects, particularly increased marrow reticulin, have been shown not to be very important. And for Eltrombopag, it's important to monitor the liver tests, and about 1 in every 33 patients, at least in ITP, does not tolerate it for that reason. Avatrombopag was first studied in the very early 2000s, and we entered almost half the patients on this study because it was such an apparently effective agent in ITP. It's given orally once a day, like Eltrombopag, but essentially has no dietary restrictions. It's just recommended, actually, that it be given with food, and that's intended to make the absorption more consistent so that dosing can be more appropriate. Also doesn't have a risk of hepatotoxicity, and I would say the two concerns at present are there's not long-term data, and that there may be an increased risk of thrombosis, perhaps because this is a relatively potent agent. The phase 3 study was published in the British Journal of Hematology in 2018 and was a smaller study, but you can see was overwhelmingly demonstrative of efficacy with Avatrombopag compared to placebo. Okay, what about aplastic anemia? Many of you may remember this, that there was a trilineage response to Eltrombopag in patients who had been unable to be transplanted and failed immunosuppressive therapy when they were given Eltrombopag alone. And while we've known that thrombopoietin has a very potent early effect on stem cells, it was not realized that you could get a trilineage response as opposed to just a platelet response in patients in this setting with aplastic anemia. That was very exciting and led to a number of additional studies. Here in the same study, though, you see that in patients 1, 2, and 4, the marrow after treatment has become much more cellular, whereas it was essentially not cellular before, whereas in patient 5, nothing has changed. And that patient was a non-responder. One explanation for that is that those patients may have had such an effective immune attack on the marrow that they have no more stem cells left to stimulate, so that would be why Eltrombopag doesn't work. However, it's very difficult to assess that experimentally, so that has to be left as just a hypothesis. The NIH team, led by Neil Young, Cindy Dunbar, and Phil Scheinberg, then did 3 consecutive cohorts of patients to try to see what was the most effective way to deliver Eltrombopag. And it appeared, and I will show you the data in a minute, that cohort 3 was best, starting with 150 milligrams of Eltrombopag on the same day 1 that ATG was given and cyclosporin was started, and then to continue the Eltrombopag for 6 months. Currently, there is some late relapse after 6 months, and they are exploring a slow discontinuation of cyclosporin over the subsequent 6 months to 18 months after this original 6 months to see if that will prevent that from happening. You see here data at 3 months and 6 months with Eltrombopag plus immunosuppressive therapy, ATG plus cyclosporin, as frontline treatment for severe aplastic anemia. What's important is if you look at the 6-month data, you can see how high the overall response rate is in purple, but you can also then see in orange that there are a majority of the overall responses, at least in cohort 3, were complete responses. However, we do not have the data, there's no randomization with transplant, but if there were a randomization with transplant, the main difference would be not that there would be a response rate higher than, say, 94%, but rather that almost all of the 94% with transplant would be complete responders, as opposed to 60% complete and 30% partial. So this is something that needs to be sorted out more in the future. And immunosuppressive responses, you can see, historically much less impressive. Now, there have been issues of clonal evolution, and it's not clear how often that's significant. It does not seem to always eventuate in leukemia or myelodysplasia, although when it is monosomy 7, that is a very bad sign. There are times you get clones and then they improve with time. And additional trials are ongoing to try to determine that. Those of you who have followed this type of work for a long time may remember that it took quite a number of years to resolve whether GCSF was predisposing to leukemia in severe congenital neutropenia patients. So let's finish with chemotherapy-induced thrombocytopenia. When doesn't it work? When does it work? What trials are ongoing? Well, the first thing is that the first-line TPO agents, here we're talking about polyethylene glycol or pegylated MGDF, which was the lead of the first 2 first-generation agents. And the hope was it would be useful in AML, where the patients had severe thrombocytopenia and were requiring frequent platelet transfusions. However, it was not really helpful at all and just resulted in an overshoot of the platelet count, as you can see in blue here compared to placebo, and didn't really avoid transfusions or minimize bleeding. So it appeared clear that if you didn't have precursors or progenitors available to be stimulated, giving a TPO agent was not likely to work. In solid tumors, and this is a study from Howard Ozer's group, you can see in the dark, in the black circles compared to the open circles, that there clearly was an effect on the platelet count as seen in ITP. But if you look at the axes, you can see that there were essentially no bleeding and no platelet transfusion saved, because this was well above any area where that would be needed. So at the time, it seemed like there was not a role in either myeloablative chemotherapy or in solid tumor non-myeloablative chemotherapy, which is why the 2nd-generation agents have all approached ITP early on. However, there was a study done with the 1st-generation agents at Memorial Sloan Kettering, and they did the study randomizing patients, and I'll show you the data in a minute, who were getting ICE chemotherapy, very thrombocytopeniogenic chemotherapy, and they were giving it to relapsed and refractory non-Hodgkin lymphoma patients. And they did the study, and then the 1st-generation agents went out of use due to the antibodies that developed to the agents, and that they cross-reacted with native thrombopoietin. So they kind of didn't think it was worth reporting the study initially. Then when the second generation agents came out, they said, well, we should report this. And what was interesting was if you look down here at the x-axis, they had a very long follow-up because of their delay in reporting. What you can also see is that long-term survival was shockingly better when the patient received on-time therapy as opposed to when their therapy was delayed, in this case for thrombocytopenia. And this basically showed in these patients, even though it was a relatively small study with only 42 patients, that if you could use a TPO agent to prevent delays in therapy, that this could be very effective. This is a slide that Jerry Soff, also at Memorial, lent me, and it illustrates the point of giving TPO agents to solid tumor patients. So you see that the green, both dark green and light green, represents giving chemo. And you can see the platelet count in blue, and the fact that it was persistently low led to dose delays and to dose reductions. And this presumably would have an effect, as suggested by that previous study, on survival. Here you see where romiplostim starts being given weekly, platelet count goes up, chemotherapy is given at full dose on schedule, and the patient did well for quite a while thereafter. What's important about this is to realize that if we were giving GCSF, we would start it after the chemotherapy and give it daily thereafter, or use Neulasta and give it once, but after chemotherapy, so that the effect would be entirely after. Jerry followed the ITP protocols and gave it weekly. So it was given on the day of chemotherapy, a week later, on the day of chemotherapy, etc., somewhat ignoring when the chemotherapy was being given. And that seemed to work very well, as had been suggested in one of the first studies of PEG-MGDF by Bob Basser and his group then in Australia. The Chinese did a study where they randomized giving the SSS bioagent either on days -4, -2, and then 9 days after a high-dose ARA-C based chemotherapy, or only 11 days after chemo. And the results were striking in that there was significantly better platelet recovery and avoidance of severe thrombocytopenia when the 2 pre-chemo doses of the SSS bio agent were given, as compared to when it was only given after chemotherapy. So there are a number of studies ongoing with Avatrombopag and Romiplostim, and Jerry published a phase 3 SOP, a phase 3 trial of Romiplostim in 2019, looking at this. And I think the point is that right now we can say confidently that you can maintain full dose on schedule chemotherapy much better with, if thrombocytopenia is the limiting problem, with TPO agent support, but it's still not formally proven that this will improve survival. And that remains to be demonstrated in some of the ongoing studies. This is the last slide just to show you that there are a number of areas where thrombopoietic agents are useful. I didn't think I had time to cover inherited congenital thrombocytopenias, but studies from the Italian group under Carlo Baldwini and one from our group on Wiscott-Aldrich have suggested that use of TPO agents can be very effective there. It's also likely it'll be effective in radiation-induced thrombocytopenia. And finally, studies are ongoing to look at its role in stem cell transplantation with often delayed thrombocytopenia. Thank you very much. I can take questions now if there are any. One question that came up that I did not discuss was the dosing of Eltrombopag in aplastic anemia compared to the dosing in ITP. In aplastic anemia, it's licensed for up to 150 milligrams a day, whereas in ITP, the maximum is said to be 75 milligrams. We have done a study looking at 150 milligrams in ITP, and the results suggest that half the patients that are non-responders to 75 a day with ITP would respond to 150 a day. And I believe that what happened initially was that the company did not want to risk extra side effects when they were getting licensed for ITP, and therefore they didn't push the dose. It's also licensed at 100 milligrams. Eltrombopag is for thrombocytopenia and liver disease. Should mention that in 2019, there was the first publication and a nice editorial in The Lancet on the use of Romiplostim for severe aplastic anemia. And in that study, doses of 20 mics per kilo were used, at least initially, as compared to the 10 mics per kilo, that's the upper limit of normal in ITP. So it appears that using a higher dose is appropriate in order potentially to increase the stem cell effects. Are there other questions? Okay. If there are no other questions, I will thank the participants, and I will be happy to be emailed if people think of questions later. Thank you very much.